floor is yours, Danielle.
Okay.
Yes. Thank you.
Well, thank you all. Good evening, everyone. I would like to welcome you all to this presentation. And of course, Novacare for giving me the opportunity to present the results of our recently performed randomized controlled trial, pelvic floor physical therapy in the treatment of chronic anal fissure. And I will present the results of the 8, 20-week and 1-year follow-up. And besides that, I will tell you a bit more about biofeedback and of course the use of the MAPLE. I'm Danielle and I'm a pelvic floor physical therapist in the Netherlands. And I work in a private practice with home practitioners. And besides that, I work in the Proctor's Clinic in Beeldhoven. That is a specialized clinic in coloproctological problems. Besides that, I'm a PhD candidate at Leiden University Center, and I hope I can defend my thesis this year. I will give you a small overview of tonight about my presentation, a short introduction in the anatomy, especially focused on the pelvic floor, the definition of chronic anal fissure, the pathophysiology, what is dyssynergia of the pelvic floor. I will tell you something about the PAF study design, the biofeedback with the MAPLE, how can you use it for diagnostic measures and also in our study. I will present you the results, a take-home message, and what kind of studies have been done with the MAPLE before. Well, a small part of the anatomy, the rectum comprises the most distal end of the gastrointestinal tract, as you know. It is a hollow tube for 12 to 15 centimeters long, and the length of the anal canal is approximately 4 centimeters. The inner layer of the anal canal is composed of the internal anal sphincter, which you can look over here, and the outer layer is the external anal sphincter going along to the levator ani muscles. The internal sphincter is the main contributor to the anal resting pressure, and in patients with CAF, a chronic anal fissure, it is known that higher pressures are found with manometry. And the use of ointments and treatment in this problem is, the main treatment nowadays to help these patients. And it's an important part of the treatment. The pelvic floor muscles are very important in this part as well. The pelvic floor is a multifunctional complex of muscle fibers, fascia, ligaments, and connective tissues that form a hammock at the bottom of the abdominal pelvic cavity. The muscles of the pelvic floor consist of superficial muscles and the deep pelvic floor muscles, and mainly the puborectalis muscle, which you can see over here, is a very important part, mainly in anorectal dysfunctions. The puborectalis muscle acts together with the external anal sphincter and urethral sphincters to close the urinary and anal openings and contracts the sphincters rapidly in response to an increase of intra-abdominal pressure to prevent incontinence. At rest, the pelvic floor muscles remain in a state of continuous contraction, and the contractile traction of the puborectalis maintains the anorectal angle at approximately 90 degrees. And this is also a very important part in the problems which I'll tell you later about. And that's what is the definition of chronic anal fissure? Well, a CAF is defined as a longitudinal ulcer in the squamous epithelium with one or more signs of chronicity, with symptoms presenting longer than 6 weeks or recurrent fissures. What is the pathophysiology of CAF? Well, it is still uncertain what the real pathophysiology is. It is assumed that pain causes an increased basal sphincter pressure, which in turn causing ischemia, and that inhibits fissure healing, generating a vicious circle of pain. But maybe the pelvic floor muscles could also be involved, because pain can give spasm of the pelvic floor muscles, an increased tone of the pelvic floor, and dyssynergia when the pelvic muscles are contracted. And that can give you a vicious circle of pain as well. And patients with chronic anal fissure, they complain mainly of pain during defecation, but a lot of patients also have pain afterwards, sometimes the whole day, sometimes until the next defecation. So mainly we think that the pelvic floor muscles are also involved in this problem. To figure this out, we did a retrospective study in 2019 in the Proctor's Clinic in Beeldhoven among 197 patients diagnosed with CAF, and the mean age of these patients was 42 years. And what we found that was 36% of the women had complaints of dyspareunia. 32% of the patients had complaint of obstipation. And with digital rectal examination, more than 1/3 of the patients were diagnosed with dyssynergia. And half of the patients, traction on the puborectalis muscle was painful, with a delayed relaxation of the pelvic floor muscles after contraction. And it should be said that most patients had problems for more than 6 weeks. We see patients, they have complaints for more than 2 years or even more, not continuously, but intermittently. So what about dyssynergia? To tell you something about that, and I will tell you about the study later on, but dyssynergia was a very important tool and part of our system. And what is it? Well, it is characterized by a paradoxal anal contraction, an inadequate anal relaxation, and/or an inadequate push effort, caused by a lack of coordination of the abdominal, rectal, and anal muscles. And well, I will show you probably this movie. Over here you see the contraction of the pelvic floor. And I will show you the movie again. You see the external anal sphincter going along to the bulbocavernosus, and this is the levator ani muscle, and especially the puborectalis. When the pelvic floor muscles are contracting, the movement goes up and anteriorly. With dyssynergia, the same could happen. And when patients are contracting the pelvic floor muscles during defecation, this is one kind of the type of dyssynergia. How can we measure this dyssynergia and how can we figure this out? Well, there are some main questions you can ask to predict dyssynergic defecation. 1, is there a sense of urge? 2, is there a prolonged training duration? Is there a sense of incomplete evacuation? And when you have answering on these questions, you can think about that there is a dyssynergic defecation involved in this problem. But the Rome 4 criteria, they say, well, you have to have 2 out of 3 tests to say this is dyssynergic defecation. And 1, an abnormal balloon expulsion test, and that's when you have to defecate a balloon which is filled with water or with 50 centiliters of water or air, and you have to expel the balloon within 2 minutes. And some studies, they say 1 minute. An impaired rectal evacuation by imaging, and 3, an abnormal anorectal evacuation pattern, which is seen by manometry or surface electromyography. So this is one part where we can use the maple to figure out if dyssynergia is involved. The diagnosis of chronic anal fissure and pelvic floor dysfunction. Well, the diagnosis of CAF is based on medical history taken, and a thorough physical exam should be performed to rule out other pathology. Before performing a digital rectal examination, it is important to explain the procedure to the patient and why, to diminish any fears and anxiety. Patients should be reassured that the digital rectal examination will only last for a couple of minutes. We choose always to ask the patient to lie on his left lateral position with the knees flexed at 90 degrees. A careful digital examination combined with a vaginal examination is another essential component of clinical examination to inquisite anal sphincter tone, pelvic floor muscle tone and function, and also to test dyssynergia. However, it should be mentioned that during medical school there is a lack of emphasis on the use of digital rectal examination, and it is inadequately used nor performed in clinical practice in patients with functional anorectal complaints. Besides that, as we know, the use of a digital rectal examination is often delayed because of the assumption that it's contradicted or should be kept to a minimum because of associated pain. But when you start treating patients with chronic anal fissure, you always asked to bring in the cream internally. So if the patient has a chronic anal fissure and has used the cream for a couple of weeks, and you can do an internal investigation, it is important to also investigate the pelvic floor muscles. And then you can also do electromyography with an intra-anal probe, as what we have done in our study as well. But sometimes a digital rectal examination is not possible, and in that case, other surgical options should be performed, such as botulinum toxin or investigation under sedation. What is currently the conservative treatment? Well, the use of extra fiber, 20 to 25 grams a day, or laxatives, the improvement of toilet behavior, moderate exercise for at least 30 minutes a day to prevent obstipation, and the use of ointment. And diltiazem or isosodinitrate are the main creams that can be used in chronic anal fissure for at least 6 weeks. And what about pelvic floor physical therapy? Well, now we come to the main topic of my talk. We wanted to know if pelvic floor physical therapy will add to an improvement of the fissure healing, and we want to investigate the efficacy and effectiveness of pelvic floor physical therapy in the treatment of chronic anal fissure and pelvic floor dysfunction. So we included men and women aged 18 years and older presenting chronic anal fissure and pelvic floor dysfunction, dyssynergia and increased pelvic floor muscle tone, which was diagnosed with digital rectal examination. And all patients had failed conservative treatment with fiber and or laxatives, and they all used the ointment for at least 6 weeks. Patients were eligible when a digital rectal examination could be performed. The exclusion criteria contained abscess or fistula, Crohn's disease, anorectal malignancy, prior rectal radiation, and pregnancy. Our primary outcome measure was tone at rest during electromyographic registration of the pelvic floor before and after pelvic floor physical therapy. The secondary outcomes contained healing of the fissure, pelvic floor muscle function, improvement of dyssynergia and decrease of pelvic floor muscle tone, the average pain intensity during defecation on a visual analog scale, complaint reduction with a proctology-specific patient-reported outcome, the ProctoProm, and quality of life with the RAND 36. It's a Dutch version of the SF 36, which you will probably know. The treatment. Well, PFPT consisted of 5 face-to-face appointments in a mean of 45 minutes in a period of 8 consecutive weeks using a treatment protocol. Patients were all referred to an extramural private practice, preferably nearby patient's home address. The pelvic floor physical therapists providing the treatment are all certified and they are all trained, and they all had a lot of experience working with the maple. At baseline, all patients received the baseline information about the chronic anal fissure. What is it? We talk a lot about the anatomy. We talk about the pelvic floor. We talk about the relation between the pelvic floor and other dysfunctions. We tell patients about lifestyle advice and toilet behavior. And that was the first meeting with at the clinic before we randomized the patients. The sessions also contained intrarectal myofascial techniques, such as stretching the puborectalis muscle, and that was done with the patient and the pelvic floor physical therapist, but also the patient has to do that at home as a home exercise treatment. When they use the ointment, we say, well, you can also bring your finger a bit deeper and do some intrarectal traction on the puborectalis muscle. Besides that, we used the maple for electromyography biofeedback. And there were 3 sessions used in the program. When the patients were not able to contract or relaxate the pelvic floor muscles, sometimes electrostimulation was used. Besides that, the biofeedback is used combined with the muscle and breathing exercises. What is biofeedback? Well, probably you will all know a bit about it, but the main goal in our study was to correct the dyssynergia, or the incoordination of the abdominal, puborectal and anal sphincter muscles, learn patients how to contract and relaxate the pelvic floor musculature, and besides that, biofeedback modulates the neurological brain-gut axis. The maple, first tell you something small about the maple. Well, the maple is a probe with a matrix of 24 electrodes to measure EMG signals from the different sides and layers of the pelvic floor musculature. Placements of the electrodes with respect to the anatomy of the pelvic floor muscles was checked by MRI, which can be seen on the left picture. With the maple, it is also possible to measure several quadrants or several musculatures. And what we did was we used the mean of all electrodes, but besides that, we also measured the external anal sphincter separately. I hope you can see this concert flow. It's I make it a bit smaller, but I will lead you into to this. Patients were recruited by the surgeon in the clinic, and at baseline, a digital rectal examination was performed. All patients received the baseline surface electromyography with a maple, and they all performed a balloon expulsion test. After that, patients were randomized to a group which started immediately with pelvic floor physical therapy and a group which started later, after 8 weeks. Patients received questionnaires, the FAS, the RAND 36, and the Proctor Prom online. After 8 weeks after inclusion, all patients came back to the clinic and they visited the surgeon and the pelvic floor physical therapist who provided the measurements. A DRE was performed and also again SEMG to measure the function of the pelvic floor. Then Group B started with the treatment, and after 20 weeks, all patients came back to the clinic, and the same was after 1 year. The results of our primary outcome, mean resting tone measured with surface electromyography. At baseline, we included 140 patients, 72 women and 68 men with a mean age of 45 years. The mean tone of the pelvic floor at rest significantly decreased from pre to post-treatment in the PFPT group, which can be seen over here. No significant improvement was found in the postponed group. Although after 20 weeks, when this group had received the treatment, also a significant decrease was found in mean resting tone measured with EMG. As can be seen, on the left side, you see a picture of one patient of the maple, and there is a high tone of the pelvic floor muscles. After treatment, so in blue, you can see a lower score. And repeated measurement analysis found that the PFPT group was found to be more effective for reducing muscle tone compared to the postponed group at first follow-up. At 1 year follow-up, all patients, we finally saw 97 patients at 1 year follow-up, and 133 patients completely followed the treatment group protocol. So 71% completed the 1 year follow-up, and in 15% of the patients, the fissure recurred. And what we saw that in the total group of patients, the mean resting electromyographic values of the pelvic floor significantly improved from baseline to follow-up at 1 year, as you can see in the values in this in the topic. When we look at the external anal sphincter, we also found a significant improvement from pre to post-treatment in the PFPT group. And also we found a significant improvement between groups at 8-week follow-up. And this is quite interesting because what we measure with our finger is high tone of the sphincters, but mainly probably the external sphincter is also involved in this problem. And the use of only ointments will probably not fit for all patients to have a relief in problems and fissure healing. So we should keep this in mind. When we look at the results of our secondary outcomes, well, at baseline, the fissure was visible in all patients. And at 8-week follow-up, the fissure was cured in more than half of the patients versus 21% in the control group. At 20-week follow-up, no significant differences were found between the groups, as you can see in this picture. And it should be said that not all fissures were cured or healed at 20 follow-up, but in these patients, less complaints were reported compared to baseline. Dyssynergia, measured with digital rectal examination, was found in 67% in the PFPT group and diminished to 26% after 8 weeks. And a further decrease was found after 20 weeks. In the postponed PFPT group, well, there was no significant decrease at 8-week follow-up, as what you can see in this picture. An important part of the treatment of chronic anal fissure is of course VAS pain scores. That is the main complaint patients has. And what we measured was VAS pain during defecation and not after defecation, because then you have to know what time, how long. So during defecation is a very important topic. When you hear about what patients say about pain, is the main pain with a fissure is during defecation, and that is why we use that. And what you can see in this picture, that as well in the PFPT group and the postponed PFPT group, a significant improvement in pain was found. Although the PFPT group was significantly better in reducing VAS pain. This is also interesting. So probably the information the old patient received about their complaints, about they give lifestyle advice, and also the reassurance that it's probably also a pelvic floor dysfunction, probably has a reflection on the pain scores, also in the postponed group. So it's always important to start with PFPT and to tell the patients what to say about their complaints. And I think that's a very important part of the treatment as well. Regarding the analysis of the repeated measures, was the PFPT group more effective for reducing VAS pain scores compared to the control group at 8-week follow-up? And no significant difference were found when both groups had received their treatment. The Proctor-Prom is a questionnaire developed by Dr. van der Mijnsbrugge. She's a surgeon from the Proctor's Clinic. And there are 5 questions you can use and ask. And this is a question about the bother patients have and what kind of complaints they have. And these 5 questions, you can use them. And there is a very nice topic about that, the manuscript she wrote about that. And we use the Proctor-Prom scores to figure out if patients has less complaints about their problems. And what we saw that also in this group, that there was a significant decrease in Proctor-Prom scores at 8 weeks from baseline. And also the PFPT group was found to be more effective in complaint reduction at 8 weeks from baseline. And the results sustained after 1 year follow-up. And finally, the results of the quality of life. We compared our patients with reference values of the general Dutch population from what is figured out from the 136 And it showed that an impaired quality of life was found in 8 of 9 domains of the RAND 36. And after treatment, significant lower scores were found in 2 of 9 domains. When you look at the 8-week results, there was less improvement, so probably quality of life has to take longer, and that is why we took the whole group and saw that there was an improvement at 20-week follow-up. And these results also sustained at 1 year follow-up. And this is what we see. At 20-week follow-up, significant improvement was seen in all the domains: physical functioning, pain, and health change. Physical role, vitality, general health, social functioning, emotional role, and mental health were significantly improved at 20-week follow-up. The results sustained after 1 year follow-up, except for the domain vitality. And the domain vitality measures energy and fatigue. So probably this, well, on the long run, probably this, topic is less influenced by chronic annual fissure. But further research should be done in the future to know if it's also in other studies. So what we can say is that the pelvic floor physical therapy is an effective treatment in patients with chronic anal fissure. It improves complaint reduction, fissure healing, dyssynergia, and it should be recommended in patients with chronic anal fissure. And these are also my take-home messages, because pelvic floor dysfunction could be an underlying cause in delayed healing and pain in patients with chronic anal fissure. Pelvic floor muscle tone measured with EMG biofeedback decreased from pre to post treatment and between groups, and has been proven effective and efficient treatment modality. It is mainstay in the treatment of anorectal dysfunctions and commonly used in PFPT. It has been proven in randomized control trials, but the success rates of these studies depends on the motivation and patience, and also on the skills of the therapists. And it should be said that in the Netherlands, we have a very good group of pelvic floor physical therapists, and we are all high educated. So we are very fortunately, we have a bit of luck that we are trained so good. In this study, biofeedback with the MAPLE has been proven an effective treatment modality, also in patients with anorectal pain. And therefore, PFPT should be recommended as adjuvant conservative treatment. Thank you very much. And these are the studies, some of the studies which are performed.
Thank you, Danielle. Are there any questions?
It's okay for me, Ono. Thank you, Dr. Danielle.
Welcome.
Thank you, Doctor.
Danielle, I have.
Thank you from England.
Thank you, Danielle, for your presentation. I was wondering, when you used the MAPLE, you focus, I think, more or less on the puborectal muscle and the anal sphincter. But did you also see a decrease of tone in women with pain problems during intercourse? I mean, did you see in the vaginal muscles also a decrease of the resting tone?
Yeah, good question. Thank you, Françoise. Well, what we did, we measured all the electrodes. So we used the mean of all electrodes. What we did is we did a sub-study focusing on patients with dyspareunia, because we did ask if patients had sexual complaints or other urological problems. But those groups were too small to talk something about it. So we did not differentiate about the vagina part or only the puborectalis muscle. We took the whole, we took the mean of all electrodes. And not only the puborectalis, and not only, because sometimes we see that patients would have a high ileococcygeus. Sometimes you see only on the puborectalis, sometimes we saw it only on the external anal sphincter. So that's why we used the whole measurement. And well, I hope in the future, I will differentiate even more. But well, when we started, this was the first study doing pelvic floor physical therapy with biofeedback in patients with a fissure. So it was a very we did start up.
Yes, it was an exploring study.
Exactly.
A little bit, of course. So more studies are needed. Yeah.
Exactly.
Okay, thank you.
More questions? Anyone? I don't think so. No, thank you very much, Danielle, for the lecture and the webinar. And for everybody and for colleagues, when you want to review again, it's been recorded, so it will be available shortly.
Okay.
Thank you very much.